while Blacks and African Americans are about 12% of the population, they're almost approaching 50% of diagnosed HIV infections. Okay, so you can see there are significant disparities there. Also with Hispanic population, which is approaching 20% of the U.S. population, but closing in on a quarter of HIV infections. Okay, and here white is just over 25% of HIV infections. So when you look at the percentage of the total population of HIV, 44% for African American, 25% for Hispanic Latino, 26% for white, and about 5% for the rest of the population. But all of these people are at higher risk for developing cancers. Okay? And so how do we know this? If we actually look over time at numbers of persons with HIV, we're going to see this number continue to, hopefully we'll see it flatten out. But it's continuing to increase because more and more people are living with HIV. It's not a death sentence anymore. It's more a chronic disease. But a good number of these individuals are also developing cancers. Okay? And so in the early days, when there really wasn't great treatment for HIV, we saw a ton of cancers, particularly those that were HIV or AIDS defining. Those have decreased, and now we're seeing more and more non-AIDS defining cancers in people who are living with HIV. Okay? So this does not only occur in the immune suppression associated with HIV, but also the immunosuppression associated with people getting transplants. And we're seeing more and more people getting stem cell transplants, liver transplants, heart transplants, kidney transplants. We're seeing more and more people with autoimmune diseases, okay? And they're getting biologic treatments. And because their immune systems are down, they are also at higher risk for these cancers. So immune suppression can also be a significant risk factor for cancer development. So here's our next question. Cancer is only a significant challenge in the developing world. Give you just a second to put your answer in. Great job, 97%. Absolutely, there's no place in the world that is untouched by cancer. Okay, so cancer remains a global challenge for all of us. So I'm going to talk a little bit more now about oral cancers, since that's my area of expertise. And our group is actually entitled Viral Oral Infections and Immune Suppression in Cancer. And for me, it starts here, in the oral cavity, in the mouth. There's nothing wrong with this person. I think they had a green lollipop or something. So that's not a disease right there, the green on your tongue. But there are many viruses in the oral cavity. And I think right now, I don't know that there's a person on this earth that doesn't understand that viruses can be transmitted by your mouth. Okay? This is one reason we're all wearing masks right now, because SARS-CoV-2 oral and respiratory transmission is so efficient. So the viruses are at the center, and these viruses cause a lot of disease and malignancy. Including these here. And I'm going to share with you some of the viruses that are associated with some of these cancers that manifest in the oral cavity. Okay? So our focus now will be on the viruses. So what we know, and this is out of order, but what we know is even though less people may be dying, there's an inequity that remains. And so overall cancer death rates have actually decreased for African Americans. And more African American men have actually stopped smoking compared to white men. However, despite these declines, death rates for all cancers combined, are 33% higher in Black men compared to white men. African American men have higher death rates for oral cancer and for most of the major cancers, lung, prostate, colon, liver, pancreas, and others. Okay? But now we're going to focus on oral. In the United States alone, every single hour of every single day, a person is dying from oral cancer. Okay? And these cancers are tough. They're associated with high mortality and high morbidity, especially in African Americans and African American men. The worldwide number of new cases is exceeding 480,000, and oral cavity cancer is about the 9th most common cancer among men. And it continues to increase every year, and that's a problem. And if we look at how we're doing, comparing all the other cancers, we're actually doing better. You know, we're doing better. We're doing a lot better with screening for breast cancer, screening for prostate cancer. All of these things have led to a projected reduced cancer mortality rate for breast, bowel, kidney, liver, lung, ovary, even pancreatic cancer and prostate, but not for oral or for liver cancer. However, given the advent of the hepatitis C cure, I think we're going to start to see cancer death rates for liver cancer start to go down as well. So there's still a lot of work. Especially in the area of these oral cancers. And we just don't have good biomarkers. We don't have good screening. We don't have good biomarkers. Okay? And we don't really understand what all of the risks are. So there's got to be research. There's got to be good research that details the genetic and environmental causes of cancer. And until we have that, we're not going to be able to move forward with saving people's lives. Okay? So from the behavioral and environmental standpoint, we know for oral cancer that tobacco use, alcohol consumption, poor nutrition, and an ultraviolet light and occupational exposure are issues. These are actually risk factors for most cancers, okay? From the molecular standpoint, we know that viruses, HPV in particular, is associated with a significant amount of oral cancer. This tumor virus causes greater than 70% of oral head and neck cancers. We mentioned earlier that immune deficiency can be a problem, like having HIV, having a transplant, or being on drugs that promote immune deficiency, like the treatments for autoimmune diseases, okay? And then there may be specific genes. So we know, for instance, for breast cancer, there's a BRCA1 gene. You can screen for it. You can see whether people have it, whether they have specific mutations. And if they're at risk, there are things that can be done. We don't know those things. We don't know whether there are specific genes that help promote oral cancer. And when we look at the oral cavity death rates, we can see that from 1973 to 1991, the oral cancer incidence rate actually climbed among Black men, while it decreased slightly for white men from 17.5 to 15.3. We know that Black males in the U.S. have an incidence rate about 1/3 higher than their white counterparts, and that twice as many Black men die of oral cancer compared to white men. Okay? And it doesn't seem to matter what stage you're in. I mean, we know the higher the stage, the worse the outcome, but we know that for Black men, when we look at Black men versus white men, and we look at cavities of the oral cavity and pharynx, those of African American descent are always doing worse, always have worse survival rates. Okay? So there's a lot of work to be done, and the disparities are very clear. You know, this cancer is a big one. All cancers are big. All cancers are big. But the oral cancers really can significantly impact your ability, your quality of life, because it's hard to eat, it's hard to speak, and it can be quite disfiguring to your face. Okay? The treatment right now, the treatments that people usually get are surgery, radiation, and chemotherapy. Okay, the surgery can leave people disfigured. The radiation is very tough because then your salivary glands don't work anymore. You get a ton of dental disease. And can you imagine your mouth feeling like the desert all the time because you're not making saliva? The other thing is you're not making those innate immune factors that help keep infections down in your mouth. Chemotherapy is provided systemically and also causes significant side effects that can impact the oral cavity and elsewhere. And the ability to live is actually compromised. What do I mean? I mean the 5-year survival rate is much lower for these cancers than for many, many other cancers. Okay, so there's a lot of work to be done there, but there are lots of areas of disparity as well. And we know that it's just not a single thing. People used to think, oh, have you heard? Did you hear about such and such? Oh, yes, she has cancer. Oh, well, she has oral cancer. Oh, well, she was a whatever. That's not it. It's not just being a smoker. It's not just being a drinker. There are whatever X is that you said, this single thing will not explain it, because cancer is not a single event. It's actually due to multiple factors, okay? And there are multiple steps to cancer, okay? What's happening is you got a normal setup, okay? Over time, as mutations accumulate, more and more mistakes are made, and our cells now are no longer able to maintain their normalcy. They're released from growth control. And as this occurs, first you start out making more cells, okay? And you're at low risk, and you have a stage called hyperplasia. And I think you probably talked about this in Dr. Baines' lecture. And over time, as you start to develop mutations and have different environmental hits, you'll begin to accumulate more mutations, and you'll move to another stage called dysplasia, which could look like this in the oral cavity, okay? And you move from mild dysplasia to moderate and then severe dysplasia. And as you move forward, you have more and more mutations develop, more and more mistakes are made, and there's a worsened ability to maintain appropriate control of the cells. And then as the process moves forward, you move from dysplasia to frank cancer, like this one we see here in the picture. Okay. So there are many, many cellular pathways that are involved in cancer. There's a lot going on that's required just to keep our cells normal, okay? And the bottom line is that the inability to maintain this normalcy and normal growth control is what really leads to cancer. But the other big thing, and I want you guys to recognize, is that everything can be going great, but if you introduce a tumor virus into the mix, and the tumor virus makes its own cancer-causing gene, and can also make other genes that disrupt these normal processes, so that's the way that the virus can promote a cancer, okay? And there are a number of viruses that are known to do this. These include HCLV, or human T-cell leukemia virus, the hepatitis viruses that we mentioned just a little bit earlier, hepatitis B and hepatitis C, the human papillomavirus that we also mentioned earlier. We'll go into a little bit more detail on that soon. Then there's Epstein-Barr virus, which is a member of the herpes virus family, and Kaposi sarcoma-associated herpes virus, which is also a member of the herpes virus family. Human papillomavirus is a member of the papovavirus family, and there are also polyomaviruses that have been more recently associated with cancers as well. So these human tumor viruses, you know, when you're growing up and someone says, oh, he's got a virus, what do we automatically think? Oh, headache, stomach ache, rest for 2 days, okay? We don't often think about viruses causing cancers, but they can, okay?
Dr. Webster,
yeah.
Forgive me for interrupting. I just want to let you know it's 11:40, so we have about 5 more minutes before we may want to stop for some questions.
Okay, great. So, how do viruses cause cancer?
All right, and let's take about 5 more seconds, if you would, please.
Okay. %. I'm so proud of all of you. All right. Well, in this last 5 minutes, let me share with you a couple of stories, okay? A couple of pictures of viruses actually causing cancer. Okay. So again, oral cancer is associated with several of these viruses, including Epstein-Barr virus, Kaposi sarcoma virus, and human papillomavirus, with HPV causing about 90% of the oral cancers that we see. So this is an example of a lymphoma that's associated with EBV, or Epstein-Barr virus. We all have EBV, okay? How do we know it causes cancer? Because when you actually look at the cancer, you can see that the patients have high levels of antibody-centered antigen. You can see the virus in all the tumor cells, and you can actually grow the virus particles out of cells that are cultured. Here's a person that we saw in the clinic. He's a 32-year-old white male. He had HIV. He came in with tooth pain in this area back here, okay? These are his molar teeth on the bottom. I took those teeth out for him. Within a week, he came back, and this was growing out of his extraction site. This is a lymphoma, okay? When we then took another picture of him, we could actually see the soft tissue lymphoma growing out of the site. And when we tested it, we could actually see Epstein-Barr virus in the tumor, okay? So here's an example of being immune suppressed and this virus-associated lymphoma growing out. There's another virus called Kaposi sarcoma-associated herpes virus. And we discovered some years ago that this is actually a virus that we all carry, just like EBV. And we're able to show that if we take saliva from people and infect cells in vitro or in the lab, we can see from this oral epithelial cell just showers and raining of viral particles coming out. And that's what we see here in this electron microscope. Okay. Well, I had a patient, he had HIV, and before we were seeing him for a different study, and he was getting a biopsy done. And we looked in his peripheral blood, in his saliva, and in his throat wash. In his throat wash, we could actually detect the Kaposi sarcoma virus. Well, what happened was he had a biopsy of his lip, and he came back in a few days, and this thing was growing out of his lip, okay? We had one of my oral surgeon colleagues come over and look at it with me, and we decided to take that out, okay? Took it out, put stitches in. He came back in less than a week. This thing was then growing through the stitches and out to his chin, okay? And then it continued on, okay? Well, in the meantime, we were able to figure out that there was capsulocarcinoma virus in this, okay? Because the pathologist was like, oh, it's a hematoma. No, we were actually able to show in the lab that this capsulocarcinoma virus was there, and then go back to the oncologists, and then they put them on radiation, and you can see that it resolved. But the bottom line is we have to be really careful in people who are immune suppressed, because these viruses can just take hold. And I'll just end with HPV. So HPV is among the most common sexually transmitted viruses, but can also be transmitted orally. More than 90% of cervical cancers are related to HPV infection, and more than 70% of oral cancers are associated with HPV infection. And around 2008 in our clinic, we started to see a lot of people come in who did not smoke and did not drink, but were coming in with cancer. And we started to look for HPV, and lo and behold, in 78%, we did a case control study, and it was one of the first to show that non-smoker, non-drinkers have high-risk HPV present. We can see that in 78% of these oropharyngeal cancers that we were seeing. And the non-smoker, non-drinker patients had 7 times the odds of high-risk HPV infection in their cancers than those who had a benign lesion, okay? What was also really interesting was among this cohort of individuals that we looked at were 2 couples, okay? And so we looked at the partners from these 2 couples who developed cancer within a year, one of their other partner. So for the first couple, they were married for 15 years, and the first person that came in was a 58-year-old female, no history of smoking or drinking. She had a tonsillar cancer, okay? A year later, her husband came in. He had a right neck mass. He had only smoked a little bit in high school and no history of drinking. He had cancer. Same thing, this other couple had been together for 10 years. The man presented first. Within a year, his partner came in with tonsillar cancer, okay? When we looked at those people, we could see that within the couples, they had the same exact virus, the same exact mutations, which says that it's likely that the virus that was causing the cancer was transmitted orally from one partner to the other, resulting in cancer development. So cancer clearly can be an infectious process. Here's an individual, and I'm going to stop after this one. An individual who had he was a 61-year-old HIV positive white male. He was doing really good with his HIV. His viral load was undetectable, but the CD4 count was not that good, okay? He had a history of anal cancer, okay? And he came in with oral warts. And I don't know if you can see these warts right here. But then when he lifted his tongue up, he had a huge ulcer under his tongue. And he also had pretty bad gum disease. And what we found when we did these biopsies were tons of HPV in there. HPV-associated oral cancer is a major challenge in HIV. We've learned that there are other organisms that may be able to promote these tumor cancers, and they are the bacteria that are associated with periodontal disease. There have been many different types of studies that demonstrate that you have up to 5 times higher risk of developing oral cancers if you have bad gum disease, okay? These have been case controls, retrospective analysis, and other systematic reviews. I'll just end, how am I doing? He's laughing. All right, I'm just keep going. The risk factor, here's a big thing. The risk factors for gum disease and oral cancer are the same. Being male, being immune suppressed, risk increases with age, and risk increases with tobacco use. Finally, non-head and neck, one last one, prostate cancer is also disproportionately detected in Black men. So here you can see prostate cancer levels are much higher in Black men compared to white men and Hispanic, okay? And recently, in a cohort of Senegalese African men, they've detected BK polyomavirus within this prostate cancer tissue, right? So what is it going to take for things to improve? One, we have to understand it. But the other big thing is there needs to be equity, not equality. There needs to be equity, okay? We need to be screening, but we first must understand the molecular lesions that actually allow for the cancer to develop, and then we can screen for them. So we got to combine research with public health interventions, and this is what it's going to take to reduce cancer disparities.
Thank you, Dr. Webster. Thank you. I didn't want to stop you because it was very good information. So students, you know, some of you have to go, we totally understand, but hopefully there'll be others that can stay and ask questions. So if you have any questions, feel free to raise your hand or put your question in the chat and we will get to it. I don't see any questions yet. I know I have a bunch of them, but I want to make sure I give the students a chance first. Okay. Well, while we wait, I have a quick question, Dr. Webster. First of all, very interesting information. So, can you explain why folks can be non-smokers and non-drinkers and still have serious issues with coming down with oral cancers?
Yes.
I mean, what's going on there? I mean, that's kind of crazy.
It's viral infections. It's viral infections, like mostly HPV, but also Epstein-Barr virus or Kaposi's. So it's these viruses, these tumor viruses that set themselves up. Where right now, people are getting HPV vaccines. And so what we hope is that maybe in 30 years or so, when these kids who are getting the vaccines are adults, we'll see a lot less HPV-associated cancer. But right now, we don't have any cures. So for the next 3 decades, we will continue to see HPV-related cancers globally.
And real quick, and I'll pass it. Real quick, and then I'll pass it on. Do oral cancers metastasize?
Yes, they do. And it's a major problem because most of the time when people come in, they already have metastasized into their neck and it's spreading around. Most people come in at late stage.
Okay, awesome. Thank you. Okay, student, Rachel Richards, do you want to ask your question?
Yes, please. Thank you so much. Good morning. My name is Rachel Richards. I'm a senior biology student here at North Carolina Agricultural and Technical State University, and I'm actually I'm setting up an HIV, STDs, and AIDS awareness event coming up soon, and I really am interested in knowing more about like the association between HIV and cancers and how I can present this information to attendees of my program. So we see that you're seeing that HIV patients are significantly more at risk at developing cancer and cancerous cells due to HIV. And that's due to like the immune system being thrown off? Is that also due to like the immunotherapies that HIV patients are undergoing and things of that nature? And how does the social determinants of HIV play a role in cancer? Is it the same?
So those are great questions, Rachel. The cancer development is mostly due to the immune suppression. It allows these viruses, they're called opportunistic infections. It really allows them to take the opportunity because they don't have the immune system checks and balances to just get out of control. The social determinants are also very important because they allow for other cofactors. There's a lot of substance abuse sometimes associated with being HIV positive. Some of the other risk factors, genetic and biologic, for instance, a large proportion of people with HIV are people of African descent, okay? So there may be other genetic factors that are yet to be discovered that predispose to these cancers. There are many other, so there are lots of relationships there that may allow for the development of malignancy in this group. And if you email me, I'd be happy to provide you additional information for your session this upcoming.
Thank you so much. Yeah, if you could drop your email in the chat, I'll be more than happy to reach out to you.
Okay, let me do that right now.
Awesome, awesome. Thank you so much for that question. It looks like we have another question. What about, okay, yeah, so what is the association between oral lichen planus and cancer? That's from my colleague, Dr. Robinson, Simona Robinson.
So oral lichen planus is an autoimmune condition and mucosal disease that occurs in the oral cavity. And there's actually a pretty high association with those with lichen planus lesions moving on to cancer. So they are thought in some instances to be pre-malignant.
Okay. I see another question. What about adults who have not had HPV vaccine?
So it's interesting because we really targeted, or the field really targeted teens to get the HPV vaccine. But we did several studies looking at people who were immune suppressed. So actually we looked at men and women who were over age 27 and who were HIV positive, and saw that the HPV vaccine, both the quadrivalent and the 9-valent vaccine, was very effective at HIV, at preventing HPV infection, even in the context of immune suppression. It's more difficult to get the vaccine as an older person. And I think that the idea is that it's likely that we've already been exposed to the viruses as older people. So as a younger person, where you may not have had opportunities to share your secretions as much with other people, and you're naive, they're thinking that the vaccine will work better in that instance. So it hasn't been, but personally, I think it would be a good thing to get it as an adult because you may not have seen all of the different cancer-causing strains. So I think there could be some advantages to getting the vaccine as an older person.
Yeah, back that bitch in
there. Let's see any other questions. Before I don't want to let anybody go before I answer questions. I'm just curious, Dr. Webster, again, we see that African American males seems to be very famous when it comes to some of these diseases. Do you think there is an issue where there's more viruses or bacteria in African American males compared to other ethnic groups? Or do you think it's other issues? You talked about some of the other factors, but do you think there could be a difference in the abundance of viruses and bacteria that could explain maybe why some of these cancers are higher in African American males specifically? Just curious.
So I don't know about that one. I do know that there are certain bacteria that are present that are much more pathogenic, that seem to colonize Black people more efficaciously than whites, okay? And what we know is those result in much more significant oral disease. So the other thing that we know is there could be host factors where there are genetic differences that maybe allow for our immune systems may not be as good at fighting against certain things. So we know, for instance, that there are some mutations in like the co-receptor for HIV that make it such that the white group doesn't get infected as easily as the Black group. So I do think this is an area to be explored. I do think there's the potential that polymicrobial infections, we know from some of our work that pathogenic bacteria can promote these tumor viruses. And we do know that Black people have a more pathogenic microbiome than the white group does. So
Do you have any idea what causes that? What is there like an evolutionary? Is there like an evolutionary reason or anything for that?
Well, it could be that it could be something like with the HLA typing. It could be with the ability of the immune system to. There may be something different about different aspects of our immune system and how it works in terms of their ability to get rid of these pathogens.
Okay.
But there's also SES. I mean, there's also the social determinants. There's access to care.
Right.
There's maybe not getting to the dentist as often, and all of these other things.
Right. Okay. Thank you. I have another question that just popped up. Looks like from a student. I'm curious about the kinds of public health interventions that, coupled with research, could help reduce cancer disparities. Are there interventions being done already? If not, what programs could be designed to address cancer disparities through the intersectionality of research and public health?
Yeah. So the Cancer Center, Lineberger, is working hard on cancer prevention efforts and screening with some of the scientific, some of the things that we're learning. So personally, I think that once we have the tools to help understand what we need to look for in terms of risk and screening, then what it's going to require from the public health standpoint is getting the word out to everybody and helping people to understand what their risks are and what they need to be screened for. So there does need to be a public health campaign, but we first need to really understand the disease so we can understand what the risk factors are and know what to look for. There are really good examples of that in prostate cancer, where we now have the PSA as a marker, or people go in to get their exams. There's good examples of that for breast cancer, where people can get screened to see if they have the BRCA1, or people are going in for the mammograms. And it becomes part of the routine medical care. And so once we understand what we are looking for, I think we can then begin to really be aggressive about public health campaigns. We do know screening for high-risk HPV is a good thing to do, but the uptake has not been broad yet.
Okay. Another question. I have another question for you. How long or quickly after exposure to a virus does cancer occur? Any particular issues on the horizon from COVID-19? That's from my colleague, Dr. Rory from A&T.
Thank you, Dr. Rory, for that question. Interestingly, these tumor viruses, especially, has anybody heard the saying, herpes are for life? Okay. We often get infected with these viruses when we are young, school-age people, and then the viruses go latent, okay? So they're basically sleeping, and not much is happening with them unless our immune system gets out of check, and then that allows the viruses to grow. A lot of these viruses are there and hanging around and just waiting for the opportunity. That's why they're called opportunists. So we could get infected at 5, but people often get infected with HPV around the time they get sexually active, right? But then the cancers don't develop until, a couple decades down the road. Why is this? It's because cancer is a multi-step process. And there have been other insults like diet, like exercise, like stress, like, all of these other habits like smoking or drinking, what have you. And it's the combination of these insults with the virus. And the virus by itself, I don't think is enough to do it. It really needs to have these other things go along. And so this the accumulation of these things over time that allow the cancer to develop. For SARS-CoV-2, we don't really know yet, but it does appear in those people who develop the long hauler disease that the response to SARS-CoV-2 may modulate our immune response to other things. Okay, and that may then we'll see what happens. But the immunomodulatory effect of SARS-CoV-2 could allow other opportunists to flourish, and those other opportunists could be tumor viruses.
Any other questions? Any other questions before we end? Well, hey, Dr. Webster, thank you so very much for your help in answering all of our questions. I will see. Oh, is there another question? There's another question? Okay. Oh, yeah, yes. Oh, yes. Thanks. Okay. Yeah, we'll get okay. Concerning the benefits of having vaccines for viruses like HPV, would you recommend the COVID-19 vaccine? Thank you for your presentation. And actually, it's funny because I was thinking about asking you that, but I wasn't sure. But a student just asked, so a colleague just asked, so it's all yours.
Well, thank you so much for that question, and I would absolutely recommend the COVID vaccine because until we get enough people vaccinated, this pandemic will continue. It will. And Laura, thank you. I see you're a student from NCCU. Go Eagles. And yes. Thank you for that question. You should definitely get vaccinated and don't wait. People are saying wait. We'll just wait and see. But in communities of color, the risks are higher. It's our communities that are getting sicker, being hospitalized, dying at a higher rate. So if you can get the vaccine, definitely get it.
Thank you, Dr. Webster. Totally appreciate that. Thank you all for joining us. Before you leave, we have another Friday webinar coming up. Cancer from a Public Health Perspective by Dr. Sharice Harrington from NCCU. So definitely join in for that. Again, Dr. Webster, thank you so much for your expertise and answering our questions. I'm sure the students appreciate it based on the questions that you received. Tim, any other announcements or anything?
Dr. Baines, thank you so much, and Dr. Webster, that was amazing. Thank you. I just want to let people know that we have recorded today's presentation along with all the others, and the best place to go is www.thebiologyofcancer.org. At the bottom, there's a link to the video library. I'll also send out a reminder to that about that on Monday, but you'll be able to go there on Monday and find today's recording of Dr. Webster in addition to the earlier recording. And we'll keep posting those as quickly as we can.
Awesome. Thank you, Tim. Thank you again, Dr. Webster. Thank you all students for joining us and anybody else, faculty, staff, and look forward to hopefully seeing you next Friday. Have a great weekend.
Thank you. Thanks for having me.
Thanks again, Dr. Webster.